So it is 10 o'clock, so let's start this promptly on the dot. So today's session is Achilles tendinopathy. We've got Mike Wilsmore, a physiotherapist, who's going to talk us through the variations and referred pains and causes and management of Achilles issues. Now, like most of us, I suppose we all know a runner or two that's had or struggles with Achilles issues, myself, so I'm very much looking forward to this one today. A couple of things before we start. Obviously, it's a presentation from Mike. Take notes as needed. There should be, hopefully, as long as we've got a sufficient time, a Q&A at the end, so you'll be able to ask your questions. What I do recommend is that if you've got some specific questions, put them into the question and answer box, and we'll try to get through them. Again, what we cannot do today is we cannot do sort of like an individual diagnosis over a webinar, because it's very difficult to do that. If you do have a specific problem that you need to speak to a physiotherapist about, then obviously Mike is available to reach out to personally, and his contact links will be at the end of this. Or of course you can reach out to one of your own individual physiotherapists, but I'm sure there'll be lots of good quality content in this that will answer most of your questions anyway. So with that said, now I'm going to stop sharing my screen now, Mike, and I'm going to pass it over to you. So just bear me 1 second.
Yeah.
So I have stopped sharing, so it's over to you now, Mike, to do the deed.
PowerPoint. Hopefully you can see my screen.
We can indeed.
Good. And then hopefully you got the big screen on big screen now. Yeah. Perfect. So first of all, thank you for coming and joining me this morning. Have you got the presenter view? Have you got the whole view?
I've got the presenter view, so if you want to put the whole view in, I'll just hide the presenter view if you, whatever works for you.
I don't know how to do that. Don't know why it's done that. What if I turn that one off? Let me just exit that and go again. How do I change it to?
Maybe you go to slideshow from the beginning when you came out. You come out.
Come out, yeah.
Slideshow. Top.
Slideshow, yeah.
Yeah, from the beginning.
Excellent.
There we are.
There we go. That's perfect.
Is that better? Perfect. Cool. Can't see all my scribble then. Perfect. First of all, yeah, so we'll start again. Thank you for coming and joining me this morning. Hopefully today I will be able to give you a little bit of an insight into Achilles tendinopathies, particularly for runners, how to manage them, and then sort of the long-term prognosis as well. So quite a lot to fit in the time, but hopefully I'll get through it quick enough that we can get some questions and answers at the end as well. If not, we can sort something else around that and try and get that at a later date. So here's what I'm going to cover today. So briefly look at what the tendinopathy is, look at risk factors, so what may or may not cause it, and then break down into tests, things that I want you doing, and then into sort of management and the thing that you all want to know, when can I run again? Which is probably why you're all here. And then we go into sort of a summary at the end of that. So first of all, a little bit about me. So my name is Mike, and so I work as a physio, both with the military, so as a civil servant, and also have my own private physio clinic as well, where I mostly work with runners, but also cover a lot of other injuries and sports as well. Pre-physio, I was a Royal Marine, and I didn't really start my running career until I was just leaving there, so at the age of 25, and then from there I've gone on to sort of represent England, not without Achilles issues along the way. So I've been on both sides of the fence with this one, so hopefully I've got some good advice that I can pass along to you along the way. Okay, so what is a tendinopathy? Okay, so it's the tendon is by your heel, obviously. Most of you, or some of you, may have experienced that. It's the strongest tendon in the body. It takes a lot of force. So when you're running just at a normal speed, it takes about 6.6% body weight at peak force, and say with more forefoot runners, that can be up to sort of 48 times higher over the distance of a mile. So in terms of load, it takes a lot when you're running, and then you stick yourself in spikes or different terrains such as uphill or on a treadmill, then those forces go up again. It's made up of two muscles, your two calf muscles, your gastroc you'll see on the picture, and your soleus as well, and they kind of intertwine into each other as it comes down into the Achilles. and then they attach onto the heel with a little bit of a wrap around the bottom of the heel as well. So some of you might have experienced something called plantar fasciitis or plantar fascia pain, and this can often be sort of interlinked with sort of a tight calf sort of complex too. So lots going on down in that area, and sort of generally can stem from issues with the gastroc or the soleus. The tendon itself is in like a sleeve, which is something called a peritoneum, and this is quite elastic, and it's quite important for supplying sort of blood and nutrients to the Achilles. So if you get any issues with that, then that can have a knock-on effect to your Achilles as well. So things like blunt traumas, catching on things, can cause a little bit of scarring in the area, and that will have a knock-on effect to the Achilles as well. So it's quite a vulnerable area, and but it's very important to allow us to run efficiently and effectively as well. Interestingly, the most vulnerable part of it is 4 to 6 centimeters above the heel. So this is where most of you get your Achilles problems, and that would be known as a mid-portion tendinopathy. If it's right down on the heel bone, then what you're looking at there is an insertional tendinopathy, and I'll go into those a little bit more later on, because there's a few significant differences in terms of how you'd manage them. The important thing with a tendinopathy is they are really, really slow to manage and to progress. I mean, you're looking at least 3 months for a basic tendinopathy issue. And that might be that the pain's gone way before then, but in terms of getting the adaptation and getting the tendon to back up to strength and the muscles up to strength as well, to get you back to full function, it is quite a significant amount of time, and we'll cover that a little bit more shortly. Okay, so what is a Achilles tendon? So it's basically an umbrella term. So just looking at pain and stiffness in the Achilles tendon, and it's often caused by repeated sort of tiny injuries, so what we call microtrauma. And if this isn't managed effectively, then this microtrauma builds and builds, and what it will do is then start to give you that sort of pain response, which will make the muscle less effective, and then you'll start to run differently and develop pain in that region. Okay, so risk factors, they come in two aspects really: extrinsic, so outside elements, and intrinsic, which is your like within your body, so to speak. So in terms of extrinsic factors, these are things like your training plan, basically. So if some of you sort of came along a couple of weeks and listened to my presentation on injury prevention, I talked a lot about not overtraining and having a nice good structure to your plan. If you don't have a good structure and you just go, right, okay, I'm going to run a marathon, or I'm going to go and do X, Y, and Z, but you haven't built up to it properly, the chances are, out of all the injuries that you'll get, it'll probably be a tendinopathy. So whether that's your Achilles, whether that's your in your hip, in your knee, and the reason is they take a lot longer to develop than a muscle. So a muscle generally will adapt in about sort of 6 to 8 weeks. A tendon, you're looking at about 12 weeks to adapt enough for you to be able to progress. So if you really ramp your training up really quickly, then you're asking for issues in the long term, really. If you've repeatedly had injuries, especially like tendinopathies, then it's worth looking at other things within your life. So alcohol consumption, for example, smoking, and also if you're on an antibiotic called oxyflexin as well. All things like this can have a big effect. Footwear, that's a presentation in itself, but if you've changed to a zero drop or a minimalist foot shoe, then you're probably putting yourself at a slightly higher risk of developing a tendinopathy. Some people get away with it and will just jump straight into that with no problems, but the majority of us, if we've gone from a trainer with a bit of a drop, so say 6 mils or something like that, or 8 mils, then what will happen is if you go to a zero or minimalist shoe, okay, you're putting a lot more strain on your calf complex, and that will in turn put more load onto your Achilles. And if you've not adapted and strengthened to allow your body to cope with that, your Achilles will generally, or some part of your lower leg will remind you about that. So whether that's the shin or the bones within your feet or your plantar fascia or something like that. So yeah, so really think about, if you are changing things, what you need to do to make that successful. And often it's a slow progress, which is not what a lot of runners want to hear. Okay, and then we look at the intrinsic factors. So some of these we can have an effect on, others not necessarily. So there are things to consider when we're building our recovery into our training plans, that some of these factors are important to consider. So things I've put down here: ankle range of movement. So if you're hypermobile, you've got really, my calves are fine, I can get my knee to a wall, I've got really good calf stretch. Okay, you're probably more at risk of something like an insertional tendinopathy, because what you're going to do is have greater range. You're going to go into more dorsiflexion, and you're going to put a lot more stress across the bone, so across the calcaneus, the heel. Whereas if you're a lot more rigid in your ankle and don't have perhaps as much range as we'd like, okay, it's probably going to put more strain across the mid portion. So ankle range of movement is really important, and again, lots can be done to address this from either side of the coin there. I see a lot of people that come to me with this issue, with really weak feet, and I think part of it is maybe the trainers or the footwear that we get used to these days, or walking around in flip-flops, but we just don't have the strength in the toe flexors. So if we can address that alongside all the other issues around an Achilles, then generally we can get this under control and be a lot more successful as well. An interesting note on that one, I was one of those people, and I sort of relied heavily on orthotics, but by using a lot of strength and exercises, a lot of loading, and a lot of time, I was able to get rid of the orthotics, and now I run as a neutral footed runner with sort of nice controlled pronation, and I don't get any problems at all with my Achilles, apart from the occasional flare up, but that's normal. Other things, sort of high blood pressure, again, not a lot you can do with that in terms of, but unless you're looking more at diet. Obesity is a big one though. So when you're running, okay, we talked about just now about how much body weight goes through your Achilles when you're running. Okay, if you're carrying a little bit more timber, you're going to put a lot more strain on it. So if you've got a bit of COVID weight, or you're not perhaps as fit as you'd like to be, just take that into consideration. It doesn't mean I'm saying drastically lose loads of weight, because that's certainly not the case. But what I'm saying is you need to consider more recovery or shorter runs, or building up a lot more slowly, if that is the case. And if you constantly keep getting flare-ups, then it might be something that's worth addressing. But with professional advice, like speak to a dietitian, speak to a nutritionist specialist, and do it with a good knowledge around it, as opposed to things like fad diets and things like that. Then obviously you've got diabetes and steroid use as well. So steroids, particularly injections or medications that involve that, they can affect the integrity and the quality of the tendons. So that can put you more at risk as well. In terms of biomechanics, what we're looking at here is how much your foot pronates. So if you collapse in really quickly, so that would depend on how you land, but also how the speed of that roll in of your foot, because we want to pronate, that's a good thing, but it's the speed of it that's the issue. And what that's going to do, it's going to put more of a torsion on the Achilles, and that can cause an effect on the Achilles and start a bit of an irritation as well. So if you're having problems and you think it might be something to do with your biomechanics, and it's definitely worth getting a specialist involved to see how you can help yourself out there. Inappropriate footwear we've talked about. So this is your minimalist shoes, your lightweight trainers, your zero drop trainers. These are going to put a lot more strain on you, really. As you get older, your ability to recover is reduced. So all the masters athletes on here, apologies. You need to try and incorporate a little bit more recovery, or reduce the amount of hard sessions you're doing within a week. So maybe dropping back down to 2 or 1 and a tempo. So you've got a little bit more ability to sort of cope with that, really. Family history. So there is some sort of vague research around sort of certain genes that carry a ability, or your body produces more protein, and that can have a knock-on effect to like tendons as well. So there can be a genetic element to it. Menopause affects your hormones, so naturally that's going to have an effect on your Achilles as well. And if you're over 30 and you're male, your tendons are probably starting to diminish a little bit. And that doesn't mean they're going to snap, they're not going to disappear, they're not going to sort of, that's not a bad thing, but it's just making sure that you keep on top of your strength and your conditioning work, to make sure that the loads and the stresses going through the tendons are adequate, and you're not putting yourself at risk. Okay, so what does it look like? So some of you probably experienced it, some of you hopefully haven't, and are using this just as a way to sort of preempt it really. So a lot of time it'll be painful to squeeze, okay, and it'll be the same on both sides. So when you're sort of feeling along the tendon, okay, sometimes you can have a little bit of a lump there as well, and that would be a mid-portion Achilles tendinopathy. And then also if it's an insertion, it will be right down on where it attaches onto the bony part of the heel. And that can be sort of pretty uncomfortable as well. But it can also be just as it wraps around the bottom of the heel as well. So it's worth having a prod around and a good feel. Compare it to the other side, unless you've got it on both sides. I say generally it sort of tends to be more on one side. So compare it to the other one. Sometimes you can have some swelling and a bit of a bursitis with it as well. But say worth trying to work out where the pain is, and that will help you to distinguish how best to manage it. Generally, it will hurt the more you load it. So when you're running, it might warm up. Okay, so it might gradually get better and then come back towards the end of the run or once you've stopped, or it might just be painful throughout the whole run. So things that involve a stretch and shortening cycle, so that sort of elastic sort of nature of a movement, so skipping, hopping, jumping, they're all things that would generally aggravate it. Dorsiflexion, so that is toes up, so toes up towards your head, will create a compression around the back of the heel, and that will often help you distinguish between the insertional and the mid-portion Achilles tendinopathy as well. The problem with this is it will all affect your function and how you are able to cope. So you have reduced strength. So if you're doing calf raises or single leg press or seeing how high you can jump, it will be reduced because what will happen, that pain will cause some inhibition. So the muscle will not fire and work as well. And therefore your performance will be reduced with that as well. And you'll see that in your running speed, you'll see that in your recovery, you'll see that in your hopping and jumping height as well. Quite often with a mid portion, it will be quite thickened. So a lot of people will have like a lump across the mid portion. And again, that's sort of a key indicator that you need to sort of address this really sooner rather than later. Otherwise, you're going to be sat on the sidelines watching your friends go for a run. One of the key features as well is stiff in the morning. So any period of prolonged rest, it will be a little bit stiff. And generally after 5 minutes, 10 minutes of walking around, it will sort of ease up a little bit once that calf has warmed up. They also have minimal pain at rest as well. So when you're sat there sort of relaxed, generally it's not that uncomfortable unless you've got pressure on it from your stool or something like that, or your trainers. They tend to be sort of relatively pain-free. Okay, so as we talked about, there's two different types. So if I bring this picture up here, so you can see the difference of the two. So the insertional, okay, so that's the one at the bottom of the picture. So down here, if you can see my little cursor, that is generally a little bit harder to manage. Okay, these are aggravated by compressive forces. So things that I'd want you to avoid with an insertional tendinopathy would be stretching. Okay, so I wouldn't want you stretching your calf with this one, because all you're going to do is compress that tendon across the bone. Okay, and then that's going to aggravate the tissue. So your recovery and your progression is going to be affected by that. So I'd look at using things like the foam rollers and your tennis balls to sort of release some of the tension in your calf, or sports massage, anything like that would be useful as well. But again, remember, these things are adjuncts. They're not the thing that's going to get rid of it. They're just going to help you manage it in the short term. And then the higher up one, so again, this is 4 to 6 centimeters above the heel bone. This is your mid portion tendinopathy. So these are a little bit easier to manage in my experience, and generally if we catch it early, so that relies on you guys being sensible and coming and being seen early with it, even if that's just for one session, going like, okay, do this, okay, you need to change this to your plan. Okay, it's worth the investment, because look how much money you probably spend on trainers or kit. It's worth speaking to someone early on to get this addressed, as opposed to going, let's let me go, settle down, because generally if you don't change something, it will continue to get worse. So listening to your body or using some of the advice from this will definitely sort of get you going in the right direction. Okay, and then so tendinopathy tends to work on something called a continuum model. So there's lots of sort of evidence come out over the years of different ways of managing it, and this is the current sort of trend, if you were. And instead of saying this is particularly one issue with it or another, we tend to slide up and down this sort of this scale. So obviously off to the left of your screen, you've got a normal tendon, pain-free, no problems at all. If you start to get a little bit of discomfort, so this is the early stages, you get something called a reactive tendinopathy. This is generally not too much going on within the tendon. If you add some rest or recovery or get some loading in there, generally that will settle down pretty quickly. If you don't do anything about it, then you're going to carry on going down that line into disrepair, which is again a lot harder to manage. You need a lot more robust program then to get that to settle down. And then if you just carry on ignoring it, you're going to get into degeneration, and the final stage past that is a rupture. It's pretty hard to rupture it, to be fair, but that degeneration phase, you're going to get a lot poorer outcomes. So your performance, once you do get the pain back under control, is going to be a lot less. So it's really thinking about early intervention and a nice structured plan with it, and that should help get you moving in the right direction. And you can slide up and down the scale. It's not right, okay, I've got this repair, that's the end of it. You can sort of get things to settle down. You can also have two elements at the same time. So you could be, particularly that you're more master athletes here, you could have a degenerative tendon with a reactive element. So it means part of the tendon is degenerated, whereas another part has just got a reactive element to it. So it's really important to not just go, I always have Achilles problems, I can't address it. Yes, you can to some degree. So yeah, get it looked at sooner rather than later. Okay, so this is just going into those a little bit more. So as you'll see, use nice colors, and they'll make sense in a little bit more in a second. So reactive tendinopathies, generally these will settle really quickly. I don't generally tend to get many issues with these. These tend to sort of, again, they still take 2 to 3 months to settle down. So I'm not expecting it to disappear overnight. And particularly that morning pain is one of the last sort of elements to disappear with it. So one of the things I wanted to put down is, so the repetitive microtrauma, so actually running, you're hopping, you're walking, your weights, they're linked to non-uniform tensions between the two calf muscles, your gastroc and your soleus. Okay, and what that's going to do, so if you imagine you've got two muscles pulling down onto an attachment, so if one of them's tighter than the other, it's going to cause a change in the tension between it. And that change in tension is what can cause the friction and the irritation within the Achilles. So for example, if your soleus isn't strong enough, okay, it's going to hold itself tighter, which is then going to cause a pull onto your Achilles, and that will just cause a change in the friction between the fibers within the Achilles, which could then lead on to the development of a tendinopathy, which is often the case, especially if you're sort of building your mileage or looking towards a race when you're sort of really up in the intensity and not necessarily doing much in terms of way of recovering properly. Okay, here just to consider really is the differential diagnosis. So just because you've got pain in your Achilles doesn't mean it's your Achilles. Okay, so these are the 4 things that are worth considering in the back of your mind, or that your therapist should be considering. What I will say is the accessory soleus is very, very rare. I think I've seen one, and generally they're quite a problem to sort of manage really. But all of these will give you a greater aggravation at a low level activity. So if you're cycling, for example, and your Achilles is still being aggravated, it could be an element of the paratenon or the fat pad that are the main issues really. And you need to address those before you start addressing the tendon, just to get the best results. Also, if the pain's more on one side than the other, so if it's more medial or more lateral, then that may indicate a different structure as opposed to your Achilles as well. And also if you don't get that warm-up effect. So if your Achilles is, you've gone for your run because you want to go for a run and it doesn't warm up and then become pain-free, then it's more likely that it could be the fat pad or a bursa that's the issue. So just think about that in the back of your mind. If it doesn't fit a normal pattern of warming up, then it's very likely that there could be something else involved as well, in which case go and see someone. Okay, so there's a few things that you can do, and I put these 3 tests, but I kind of don't want you to do them until a later stage in your rehab, or if you do them, then it should be only once a week as a test. And then obviously put a daily load test, but I'll come on to that in a second. So a calf raise, what you're looking at is progressive. So in the early stages, you're going to do it with 2 feet, then you're going to progress onto 1 foot. You're going to change the height, you're going to change the speed of it. So it's very much a test, and once you can complete the test of in one zone, so for example 3 times 30 calf raises, if you can do that fine with 2 feet, then you'd go on to 1 foot, or you'd go to doing it quicker, or you go to doing it higher. So you only ever change one element at a time, and then you only do that each week. Pogo jumps, again, later stage really, so this is more coming into your plyometrics. So this is, and again, I'll go into the stages in a minute. This is pogos and single leg hops are more your stage 3, stage 4 areas that you want to be sort of considering these tests. Calf raise will probably go all the way up to that point, but then we're starting to get a bit more loading, a bit more elasticity into the muscles and the tendons, sorry, not the muscles. Then we're likely to be using these high level tests then. The pogo jumps, simple as it sounds, okay, 2 feet, sort of jumping on the spot. Okay, imagine you're a pogo stick. Don't know if they still have them these days. Maybe I'm sure my age a little bit there. And then your single leg hop. So obviously on a single leg, okay, you've got a lot more force going through it because it's not spread across your 2 legs. So again, this is high level, and I generally won't get any of my athletes doing this until we're well back into the running phases really. In terms of the daily load test, this is something that is good to do every day because it gives you an indication of how your Achilles is coping. Okay, and this should be done from the same starting point, and it should be done at the same time each day. So, for example, if you're an insertional tendinopathy, so the pain, again, that's the pain down at the heel, then I'd want you doing that from a plantigrade position, so your heel's not dropping off the edge of something. So do it from the floor. That way you are not compressing the tendon and you're not going to aggravate the tissue before you've even started the day. So again, thinking about what things aggravate it and trying to eliminate those aspects of it really. But we can get, if people want more information on those, we can sort of go into that, or I can send a PDF out with a bit more of a breakdown of them. But I want to go into the other aspects of it really. Okay, so management. So this is my golden rule really. Okay, so anyone that's come to see me for tendinopathy, and there's a few of you that have done that I've seen on the course. So you'll see this and go, okay, yeah, Mike's going to sort of jabber on about this for a little while. It's easy to think about. You use a traffic light system. Okay, so if you are running and your pain is 0 to 4, okay, I'm happy. You can run at that. Okay, but it's not just while you're running. Okay, so it's while you're running, after you've finished running, and the next day. Okay, if your pain goes above a 4 out of 10, okay, you need to back off what you've done. Okay, you need to give your tendon more time to adapt and more time to recover. Otherwise, all you're doing is going to come down into a downward slope in terms of your ability to adapt and progress, and your pain will start increasing again. So 4 out of 10, like that's the maximum. Okay, and if you're going for a run and pain's going, oh, it's a 1, it's a 2, it's gradually creeping up. Okay, cut your losses. Okay, stop early. Okay, because if you keep pushing up towards those higher ends, you're going past the capacity that tendon currently has. And you're going to end up aggravating it, and that's not going to sort of help you in the long term, really. It doesn't mean it's going to cause any sort of bad issues unless you do something silly, but what it will do is reduce your ability to adapt and recover. So if we're thinking about those consistent week-on-week progressions, you're going to have to go, well, I need to take a week off now to let this settle down. And that's the last thing I want. I want you running. I want you consistently running. Therefore, if we use this traffic light system, it tends to be a lot more successful. Some people don't like using numbers, and runners generally, they'll make the number fit their criteria, really. Mike said a 4, therefore it's a 4. So think about how it feels. So if you're changing your running style, so hobbling a little bit or changing your foot strike, or it just generally hurts, then you need to back off a little bit. So a little bit of discomfort is okay, but if you're changing your running style because of it, then yeah, you need to cut what you're doing, have a think about what you're doing, and sort of adjust from there. Okay, so other things to consider alongside the traffic light system is how we can reduce things that are overloading it. So the short answer, stop running. Okay, but that doesn't mean you stop training. Okay, so you can always cross train. you can still be doing weights, you can still be doing conditioning. Obviously, gyms are due to be opening soon, so that's going to be useful in terms of like getting the strength work there, but you can always improvise with home-based stuff as well. However, it doesn't mean you have to stop running, okay? As long as you can get your pain below that 4 out of 10, okay? And if that means you drop back to 30-second jogs, and say many of my athletes I've worked with will know that they've had to go back that far to allow them to start getting some load and force going through the tendon, then that's what you need to do. Otherwise, you're just going to keep going, oh, I've had a week off, I'll go back and do a 30-minute run, oh, it hurts again, okay? And if you keep doing that, you're not going to get anywhere, okay? And it will just go down that continuum from reactive, disrepair, degeneration. So you need to sort of think about what you're doing and have a reason behind why you're doing everything, really. Minimize the compressive forces. Again, this is more for your insertional tendinopathies. This is add a heel wedge, so it's going to bring your heel up slightly higher. So again, you're not compressing into that sort of loaded position quite as much. Increase the trainer drop. So again, if you're a minimalist trainer or a zero drop, then get ones with a bigger heel. Not your platforms, but so something that's going to give you a little bit of an offload. So same idea as what a heel wedge will do. And again, as I said before, avoid stretching. Use something like a foam roller, tennis ball, massage to help with these aspects of it. And as I've already said, continue to exercise. Run on the flat. Okay, this is quite an important one, and not always possible. Okay, I know some of you live in hilly areas, but if you run on the flat, there's less load going through your Achilles. Uphill increases because you tend to be more on ball of your foot. It tends to put a lot more load through the Achilles with that. So if you can find somewhere flat, even if it's running around a football field or running up and down a flat bit of street, at least it's a way in, okay? And that's one of the big things that alongside the traffic light system is you need to find a way in to get to manage this. If you just keep peaking and troughing, your progress is going to be sort of relatively slow with this. Okay, other things to think of. So think about heel striking. So though I'm not a big advocate of big changes of running style because they can often bring other problems, heel strikers tend to have less load going through their Achilles. So your midfoot and your forefoot, your heels, when you're landing in those positions, your heel's already off the floor, and that puts a lot of strain through your Achilles. So it might be worth slightly changing your running style in the short term. Okay, it doesn't mean you can't go back to sort of midfoot, forefoot running, but if it allows you a way in to get your pain under control, then that can be a useful element as well. And again, all these things need to be done on an individual basis. There is no recipe for do this and it will solve everyone's problems. It's got to be weighing the problems up left and right for you as an individual. Increase your cadence. So if your leg turnover is quicker, there's less strain going through your Achilles. So if you're bit of a loper, bit of a sort of plodder, then it might be worth sort of shortening that stride slightly, increasing your cadence. And again, this has been shown to reduce the load that goes through your Achilles. Run outside, okay? So, I mean, there's plenty of fair weather runners amongst us here. If you're running on a treadmill, because of the way it changes your running style slightly, it will put more load through your Achilles. So if you can get out and do your run outside, then that's going to be a lot more beneficial in terms of your long-term management as well. I'd also be avoiding things like soft grounds and sand as well, because they're going to put a lot more load onto your Achilles, regardless of how your foot strikes the floor. Stick to the pain traffic light system, as I've said, and I'll probably sort of keep chirping on about that. And then use ibuprofen. Obviously, I can't tell you how to take medication. It's worth checking with yourself with a doctor with that one. However, especially in the earlier stages, there is shown to be some inflammation within there. So if you can reduce that slightly, then that can help with the early stage management as well. There's lots of evidence coming out about collagen supplements. Okay, so again, I'd speak to a dietitian around this aspect and see what they'd recommend with this. But things look such as sort of gelatin, taken, I think it's about 45 minutes to an hour before you exercise, can be shown to help improve a tendinopathy. So definitely one that needs a bit more research, really, but might be worth considering or doing speaking to a specialist about that. Okay, so now we're going to get onto the return to running. So the bit that you're all here for, really. There's 4 main stages to it, really. So in the early days, you're going to stick to this low load. Okay, so this is your isometrics. Okay, this is the most important part of your way in, really, is getting this pain under control. Okay, so in the early stages, the only thing I want you to think about is I need to get this pain lower. I need to get within that 0 to 4, okay, and I need it to consistently be there. I never want to go above a 4, okay, and if you're doing that, then I want you to use the isometrics to do that. And these are done sort of multiple times throughout the day. And a good example of that is a calf raise hold. So up into the ball of your foot, okay, and you just hold that position, okay, and you can hold it for up to 60 seconds. And I'd aim to do sort of 3 to 5 of those each time you do it. So you can see that can kind of eat into a lot of time, but you don't need to sort of set too much time aside for it. While the kettle's boiling, while you're brushing your teeth, while you're stood in the queue, these are all times that you can be doing, well, I can do a little bit of loading. And there's good evidence that this reduces the pain aspect of the tendinopathy, so it can really help get things under control really quickly, and then we can start to go on to the sort of the medium and the higher loading elements of it. So medium load, this is going to be your body weight to start with, so things like a calf raise. One of the important things to say with this aspect is remember that when the majority of your running, you're using the soleus muscle. So this is the lower muscle, so not the big calf muscle that a lot of you see. It's the one that sits below that. Okay, so the soleus muscle is important in terms of it doesn't go across the knee joint. So generally, your knee's always got a slight bend on it when you're running. You never really want a fully straight leg, so soleus becomes the prime sort of loader and mover. So most of your strengthening exercises should be done with a slightly bent leg. Doesn't mean it doesn't work when you've got a fully straight leg, but if we want to focus on a weakness in particular, then I'd be looking at sort of bent knee calf raise for you. And then to progress this along, we're going to put some weight and load with that as well. And again, maybe take a screenshot of this page and you can sort of see, or I can send out as PDFs, that sort of thing. You can see the sort of reps and sets we want you doing that. And again, this can be done sort of daily to start with. So lots of load and lots of time taken up in the earlier stages. But then when we go into a higher load, we're only doing this every sort of second to third day, really. And we've got running well involved in by the medium stage as well. So, but I'll come on to that in a second. Change how you do it as well, because if you're not getting a lot from these things, okay, then think about how long you're holding it for, the speed of the movement. So if it's aggravated with quick movements, then perhaps you want to do it slower. And then think about the position of your foot as well. So even if you're doing circuit-based stuff, so things like squats, changing where your foot is in terms of position, will change how you're loading through that Achilles and through your calf muscles as well. Obviously, something like a squat, they're not the muscle that are doing the movement, but they're still creating that stability with your foot and your ankle as well. And then consider the rest as well. So if you need a bit more rest than what it says on here, then that's not a problem at all. It's all about finding what works for you best, really. And as you can see from the heavy load, so this is heavy, slow resistance. So these reps are really slow, but they're heavy. Okay, you're talking 8 rep max, 15 rep max. So you must, like, you're finishing a set going, oh, I couldn't really do many more reps. Okay, that's the amount of load you need to be putting through with a high load. And you need to consider that in terms of how you can create that. So backpack with some weight on, get into the gym using a leg press or squat rack, just to put enough force through it. So again, not always achievable for everyone. So again, it's trying to make your lifestyle fit around what abilities you have, really. And in terms of plyometrics, this is very late stage. This is not something I'll be doing until you're back running sort of 30, 40 minutes, really. And that's something that I'll have in there sort of long term, really. Okay, this is a good structure. Okay, so what I'm looking at here is how do we break it down? And each stage generally takes about 4 weeks. Okay, so as I said, none of this happens quickly. It's got to be prolonged, it's got to be consistent, and it's got to be well thought out in terms of how you sort of shoehorn it into your life. So early stages, so stage 1, so this is your isometric holds. Alongside this, you can be cross-training. And to be fair, in stage 1, you can still be running. Okay, so don't think, oh, all I can do is like an isometric calf raise. Not true at all. Okay, if your pain levels are low enough, okay, you can be running to some degree. But if you're in the stage 1, okay, and we can't sort of put you in straight at stage 2 or stage 3, then you're probably running about 4 to 6 times 30 seconds at this point within a walk. So just to make it a little bit more worth your while in terms of putting your trainers on. And then as you can see, when we go stages 2 and 3, we're alternating where we're doing the loading. So if we go back to this one, you can see that one day we're doing isometrics, next day we're doing calf raises, and then the other day we're doing the heavy slow resistance. And the reason for that is this, okay? So this is what your tendon is doing. So once you've loaded it, so you've been for your run, okay, you're going to get increased protein synthesis, okay? So that's the green line at the top, and then you're going to get degradation of the tendon as well. So what you need to do is allow that adaptation time, so that way you can give the tendon enough time to adapt and allow you to sort of go into some heavy loading again. So obviously higher intensity runs, longer runs will create more of this, and your more slower recovery runs or shorter in duration will have a less of an effect either way. But you need to consider this in terms of your training. Unfortunately, as a masters athlete, okay, this does take a little bit longer, so that's why you need to be considering a nice good gap between your harder sessions, really. Okay, so when can I run? Okay, so it's $1 million question, isn't it? So you need to fit all of those things into your plan. So traffic light system, that's your number one go-to. If my pain is below a 4 out of 10 and it's not aggravated above that, then I can run to some degree. Okay, but it needs to be structured and it needs to be well planned. So a lot of my athletes, I'll start with, let's say 4 to 6 times 30 seconds. If they have no problem with that one, then they'll miss a day running. Okay, and then the next day they'll do 4 to 6 times 60 seconds. Okay, and again, provided then they go up into 30-second sort of intervals. That is not always the case. Okay, and that will vary with some people. Some people I get to do a couple at that time at the sort of 30 seconds, then we go up in blocks. Others will sort of just bounce up quite nicely, and it depends where they are along that continuum. So again, it's not a one shoe fits all. It's got to be sort of very dependent on your symptoms. I'll give you an example of how I'd sort of manage to an Achilles tendinopathy with most of my patients. So I start with decreasing the load and the tension, and definitely put isometrics in there straight away. I'd look at what is causing the tension. So probably definitely if it's a mid portion or well, either side, to be fair, I'd be looking to reduce the tension in the calf. So your foam rolling, your tennis ball, your massage. And I'd add a lot of cross training as well, because runners like to run. So I need to replace it with something. Okay, and if I tell you not to run, I need to give you a good reason why. So if we can set out a good structure with you, so using those elements, your isometric loading, your calf raise, your calf loading, or your calf release, and then some running to a degree, but with a large element of cross training, then that's really a good way in to get you to sort of progress it on then. Then we'd add some body weight loading in, so that's your normal calf raises with a bench and a straight knee, and then we'd add some weight, and then we'd go on to some more plyometric based stuff. So something like a supported hop, so 1 foot on the chair in front of you and then hopping with the back leg. Okay, so that way you're reducing the load and the weight going through it, and you're able to progress the stretch and shorten cycle and just condition the tendon a little bit more. But all these stages take weeks and weeks, so it's really important to put your head into the game and go, right, okay, I know this is going to be a long game, but if I want to get back to running, then this is what I need to do with it, really. And it's continuing to do it as well. So continuing to do your strengthening exercises, because if you just get back to running and then stop doing your rehab, it'll probably come back. Okay, because you need to, as you would in a race, you run through the line. Okay, you don't just run to the line. You need to keep going and create a better capacity, so you've got a better coping mechanism, as opposed to just getting to that point where you can cope, because as soon as you stop, probably going to lose some strength, and then there's a high chance that it might come back as well. Also, foot strength. So a big part of my sort of rehab with my patients or my clients is foot strength. So I'll get them doing a lot of toe clawing, sort of big toe pull downs, sort of pronation, supination with the foot in different positions as well, just to create some strength within the foot, because that's going to help with the long-term management of an Achilles as well. Okay, so what is the long-term prognosis? Not great, but achievable. Okay, so as you can see from here, it takes about 3 months, even for the most basic tendinopathies to change, whereas others can take up to about 6 months. You will get a fluctuation in your pain, so it can take up to a year for that to settle. But as we've sort of just gone through, really, it doesn't have to be pain-free before you start running. It needs to be a controlled pain. These are really irritable, okay, especially if you're more into the sort of disrepair stage. you need to really sort of manage these things pretty well. And if you don't, okay, you don't do the rehab, you don't do the loading, okay, the chances are up to sort of 25 or 27% of sort of reoccurring. So the intention of keeping the rehab into your plan is really important. And as you can see, that they're sort of quick to aggravate as well. Only 25% of these are fully recovered. So what I mean by the full recovery of the muscle tendon function there is, though you might be pain free, okay, you not necessarily have the full function back of the muscle and the tendon and how they interact, okay, because the pain in the tendon or the dysfunction in the tendon will disengage how well that muscle fires. So that's why building that strength and building that sort of plyometric ability in those later stages will help you to increase your function, because just because you're pain-free doesn't mean you'll perform or be as efficient as you were at the start. So it's really thinking about the long-term plan and getting someone on board, whether it's your coach, whether it's a sports therapist or physiotherapist, making sure that they can sort of help progress you along those stages to get you back up as functioning as high as possible. Okay, now only 65% of people are pain-free at 5 years, so expect this to fluctuate as you go along. Okay, so in summary, manage your load. Okay, this is really important. You need to make sure that your training plan is well managed. Okay, you're not just jumping in and out going, okay, I normally run an 8-minute mile and therefore I can go straight back into that. Not a chance. Okay, you need to be running these at a comfortable speed. Okay, it's not a session. Just because you got a 30-second rep doesn't mean you need to sort of like sprint down the road. Okay, it needs to be nice and slow, nice and controlled. Okay, pain reduction is your primary focus at the start. If you don't get the pain under control, you're not going to make it into these sort of stage 2, 3, 4s. Okay, so get that under control, and that's your primary focus throughout of all of this. And be consistent. Make the time. Okay, you make the time to run when you can run, so make the time to do your rehab. If you don't do that, you're not going to progress. Okay, and expect it to flare up and down. Okay, so sometimes you might have just pushed it a little bit too hard in terms of the run. You may not have been quite ready for that, or you might have just put a bit too much load through it in terms of the speed of the reps or the amount of reps that you're doing. So just write everything down as you go. Have a record. That way you can go, okay, actually, yeah, did a little bit too much there. Take 10% off, give it a chance to recover, and then progress through again. Okay, compare it week to week. It's not going to change day to day. And if you try and do that, you're going to tear your hair out. Okay, you need to look at it over a long-term period. Otherwise, you won't make much progress. Okay, and you'll just be fraternizing over every single little sort of element of change. Okay, whereas if you're looking at it over a longer term period, you'll get a lot better effect. Okay, remember, symptom-free doesn't mean that you've done the job. Okay, you need to continue to strengthen this to make it stay away. Okay, and just passive treatment. So I know I've not mentioned about your shockwave therapy or your ultrasound or your massage. Okay, because they're going to help. Okay, some of these will help a little bit, but there's not a lot of evidence to support that they do a lot. Massage can be really useful in terms of managing your pain. Okay, but the others, there's still very mixed evidence with that, and some of you may disagree with that. But in my experience, the only way to get this better is to get it stronger, to reduce your pain, and then control your reintroduction back into your training. And that is me done jabbering. So any questions at all?
Excellent presentation. That really enjoyed that. Very informative.